Marilyn approached me a little while ago, just knowing that I was going to be presenting in January, and asked if there was any articles that I thought we should do or something we could talk about. And I'm obviously very interested in ultrasound, as that's what my focus is for the year. And Rob and I helped Rob teach an ultrasound course, a EFAST course to the general surgery residents. And they were, as part of their protocol for assessing patients in the trauma bay doing their FAST exams, was adding the ultrasound and doing this EFAST exam. So I thought it would be good to look at some of the literature of where this came from, because they're incorporating it and they feel that the evidence is there and they're doing it. So I figured that we should understand a little bit about this ourselves and decide if this is something that we want to do as well. I'm obviously heavily biased, but we'll go through that a little bit. I'm going to spend a few minutes talking about the actual paper. It's pretty short. I assume you all read it, so we won't go into incredible detail. Do a little bit of a critical review as we go through it, and then I'll show some images and what this actually looks like in the trauma bay. And then we'll get to those questions that Dr. Sedger and Dr. Pringle brought up about how we can incorporate this into our practice, and does it even matter? And I think I have some thoughts on that, and perhaps we can have a discussion afterwards. Why did they do this study? Because pneumothorax is common in trauma, and some studies show that the incidence of pneumothorax and polytrauma is as high as 20%. That's a study out of Calgary. Clinical exam is not very good, as Derek alluded to, with keen residents freaking out in the trauma bay, hearing decreased air entry and want to put in tubes. There's studies showing that the true positive for a physical exam for pneumothorax is only about 60%. And chest x-ray misses a lot of pneumos. It may miss up to half of them in some studies, because most of these in sick trauma patients are supine, as was brought up earlier. And CT scan is the gold standard, but it's time consuming, and it's away from the trauma bay. If you have a sick patient, you don't really want to be taking them there. Ultrasound has the advantages of being rapid, bedside, easy, cheap, no radiation. It's dynamic. You can repeat it over time, and we'll get into that a little more later. The objective of the study was to investigate the utility of surgeon-performed extended focused assessment with sonography for trauma. They call it the EFAST, for the diagnosis of pneumothorax. The design, now just like in the other study, there's not a lot of details here, so we kind of have to infer a few things and just wonder about the rest. They said it was prospective over 1 year. We have no idea if this was convenient sampling, or if this was all the patients, or if this was weekdays when people are available, or was this on weekends. We have no idea, so there could be some selection bias there. It was done at a level 1 trauma center, so that's similar to us. And they included patients that had a physical exam, an EFAST, a chest x-ray, and a CT. So they had to have all of those components completed to be part of this study. So the inclusion criteria was polytrauma, blunt and penetrating trauma to the thorax. They excluded extremity injuries and just abdominal trauma. Exclusion chest tube placed without sono or chest x-ray. So that meant that they could have a chest tube placed, but if they still had the sono and the chest x-ray, they were included. And like I said, penetrating abdo or extremity trauma only were excluded. So they had to be something in the chest for them to get into the study. So let's just talk about that briefly in terms of a little bit of just critically appraising it a bit. Was there diagnostic uncertainty in the trauma bay? Yes, there always is when they initially show up. Like, you don't know what injuries they have, so that's common. Was there blinding? No, and this is potentially a big problem in this study. They didn't say who was reading the exams. Was it just the trauma team? Was it the resident? Was it the trauma team leader? Was it radiology? We have no idea who was reading it. It should be an independent, blinded assessor reviewing all the images without knowing the clinical situation. I have no idea if they did that, but I highly doubt it, since they didn't say it. Because knowing the results of one study could influence how you interpret or how well the subsequent studies perform. And that's a methodological issue in the paper. Did the result of the test being evaluated influence the decision to perform the reference standard? No, because by definition in this study, they had to have all of the tests, the physical exam, the ultrasound, the chest X-ray, and the CT to get in. So they had all three, sort of regardless of the results of any one of those. So we'll go through some of the results. There was 204 patients over a 1-year period, 152 males, 52 females. I mean, I think we all see more males than females in trauma. And like Ahmed was saying, I don't know our numbers here at LHSC over a 1-year period, but we have no idea how they sampled these, so we don't know what the denominator is again. There was 21 pneumos, which was in 10.3% of the patients, 12 blunt, 9 penetrating, and they did go through it in the paper and break those up and go through them separately, which I'm not going to because I don't think that we would learn too much new from doing that. So we'll just go through the combined data. So let's just go through the results for each of the assessment modalities. So the first was physical exam. Just go through some of the raw numbers before we get into the stats. The physical exam was suggestive of pneumo in 17 patients. So all the patients that rolled through, they said, these 17 we think on physical exam have pneumos. 13 of them were shown to be true positives. 4 of them were false positives. 8 of them were false negatives. So it's kind of all over the map. So there were some that they thought had it that didn't. There were some that they thought had it or didn't have it that did have it. So it really, just looking at those numbers doesn't look like it's very good. Chest X-ray was positive in 16 patients. Again, we don't know if these were supine, if they were upright. We have to assume in most of these traumas that they're going to be done in the trauma-based supine, which aren't as good for detecting pneumothorax, but they didn't say specifically in the paper. 15 of those were true positive. 4 of them were missed, and 1 of them was a false positive. So looks, just glancing at it, better than physical exam, but, and 2 had chest tube prior to chest X-ray. So, but looking at that, it looks a little better than physical exam. Looking at the EFAST was positive in 21 patients. 20 of those were true positives, 1 false positive, and 1 false negative. So that looks, just glancing at it, you can see a trend there. So let's go through some of the statistics just to see what they found. I know this is a busy table, but we'll go through it sort of bit by bit. The first one, the clinical exam, I'm not going to belabor the sensitivity, specificity, definitions, and all that since Ahmed already did. But the sensitivity was 62, specificity 98, positive predictor 76, and negative predictor 95. So obviously not very good sensitivity over a positive predictive value there. Chest X-ray, a little better, but similar trend. So the sensitivity was almost 80 with a high specificity. So if you saw it, it was likely to be real. And then a positive predictive value of 94. And then for EFAST, obviously, you can see where I'm going with this. High sensitivity, high specificity, high predictive value, and high negative predictive value. One thing that they didn't do that you should do in these types of studies is report 95% confidence intervals, because that tells you an idea of spread. Like, are we looking at a massive range, or is it a tight confidence interval that makes sense, or would put more weight to the results? So I just well, actually, Shelley did this for me. She calculated the confidence intervals. Thanks, Shelley. So just to present what it is for the FAST exam, the ultrasound portion, the sensitivity they reported as 95% with a confidence interval of 77 to 99. So those are a bit wide. Specificity is a much more narrow confidence interval. Positive predictive value is actually the same confidence interval there, and negative predictive value is also a very tight confidence interval. So just to give you an idea that this isn't a perfect test by any means. And then Ahmed brought up likelihood ratios because in most studies of diagnostic tests, those are the things you look at. sensitivity, specificity, positive, negative predictive values, and likelihood ratios. And they didn't do the likelihood ratios, but for our purposes here to learn about diagnostic tests and the statistics, we decided to get into the likelihood ratios. I think the take-home point for likelihood ratios, correct me if I'm wrong, is that the higher the positive likelihood ratio, the stronger it is in predicting disease. The smaller the negative predictive value, the better it is in predicting the absence of disease. So we'll go through the example for this study, and I calculated the likelihood ratios for all three modalities. So for clinical exam, the positive likelihood ratio is 31, and the negative likelihood ratio is 0.39. And I know when I first started looking at these numbers, really, these numbers don't mean anything to me, but apparently a likelihood greater than 10 for a positive likelihood ratio, or a likelihood or negative likelihood ratio less than 0.1 generate large and often conclusive changes from your pre to post test probability. So you can see here for clinical exam, the positive likelihood ratio is 31. So if it's positive, then that increases the chance that yes, they do have a pneumothorax. The negative likelihood ratio is not as good here, so it is not as good as excluding pneumothorax. Moving down, chest X-ray is better in each, so the positive likelihood ratio goes up to 79, the negative down to 0.21. And then EFAST, as you can see, the positive likelihood ratio goes up again, and the negative likelihood ratio is 0.05. So this gets into the area where we're less than the 0.1 for a negative predictive value. So it is much better than these other two tests at excluding pneumothorax. Does that kind of make sense? Good. So are the results reproducible here? Like if we were to do this study, I argue that yes, we could do this and we would probably do it much better. Are the results applicable to the patients here? I think so. I mean, they didn't present a lot of data on the patients themselves, but I assume it's North America. Our trauma patients would likely be similar. And will the results change my management strategy? Well, I think it should, but like I said, I'm biased, and we'll go through that in a few minutes here. And will patients be better off as a result of this test? Yes, in specific situations, and we'll get into that because I know Derek's going to be asking questions shortly.